Okay, I got that out of the way now.
Now tell them the secret.
Well, before we begin, there's going to be a more or less formal introduction, but we've got to acknowledge the students of the Adler Graduate School who helped put this together. Dan Haugen extended the invitation, Dr. Haugen did as academic vice president, but there was a cadre of students, but I see two who are the principals in this. So Patrick Robinson, right here. You can't see him, but he's right here. Step over this way. There he is. He's our he's president of the Adler Graduate School Student Association. So he, and then the other person's Wendy. I know you were part of the. This is Wendy Fries. Now, I know the two of you were instrumental in this, but now you've got to point out who else ought to be acknowledged from the student group.
Michelle?
Michelle Clark. Oh, yeah, okay. Come here. Come on.
Makoto, who's the cameraman?
Makoto, the cameraman. There he is.
Terry, you want to stand up?
Terry, there you are.
All right.
We got some extra help from Ryan today with all the signs. Thank you.
Thank you very much. Anything you want to say?
I'm not ready yet.
Okay. All right. Well, great. It would be you know, a crime to start without acknowledging them and all the work they've done. So anyway, thank you very much. Well, good evening. My name is Roger Ballou. I serve as Adlerian Program Director and a faculty member here at the Adler Graduate School. We're absolutely delighted that you're here with us this evening. It's a good turnout. It is my task during the next 5 minutes to introduce to you Dr. Harold Mozak. I was extremely honored that our academic vice president, Dr. Dan Haugen, asked me to do this. My introduction has two parts, the formal and the informal. Actually, the informal is more important, and I expect that Dr. Mozak would probably agree. First, I will read to you Dr. Mozak's biographical write-up as it appears on the website of the Adler School of Professional Psychology in Chicago. Now, this is the formal part. Dr. Mozak serves as chair of the Doctoral Scholars in Clinical Psychology program at the Adler Graduate School, at the Adler School of Professional Psychology in Chicago. Dr. Mozak earned his BA in psychology and PhD in clinical psychology at the University of Chicago. He is a diplomat.
59 years ago, last week, St. Patrick's Day.
He is a diplomat in clinical psychology of the American Board of Professional Psychology, a life member and fellow of the American Psychological Association, and a licensed clinical psychologist. Dr. Mozak teaches courses in Adlerian theory and methods, as well as other clinical seminars. His additional interests include the use of humor, the role of the spiritual in psychotherapy, multiple psychotherapy, and group and couples therapy. Now, for the more important part, the informal introduction of Dr. Mozak. For starters, tonight you will learn from one of the living legends of our field. In today's contemporary parlance, the name Harold Mozak is synonymous with the past, the present, and the future of Adlerian psychology. Dr. Mozak, along with a small cadre of distinguished scholars and clinicians, was selected by Dr. Rudolf Dreikurs during the 1960s to become part of Dreikurs' inner circle to pursue the establishment and practice of Adlerian psychology. Dr. Mozak worked alongside Rudolf Dreikurs for many years. In addition, Harold Mozak is recognized as one of Adlerian psychology's most prolific authors, exceptional clinicians, and engaging teachers. Dr. Mozak has traveled far and wide to instruct about and demonstrate Alfred Adler's system of personality theory, psychotherapy, and healing. In this connection, Dr. Mozak has received worldwide recognition for his efforts in the interests of Adlerian psychology. Tonight he will teach us. I have sat through many lectures by Dr. Mozak. He is learned, good-humored, and challenging. I left many of Dr. Mozak's talks saying to myself, it'd be nice to be able to do things more like him. I think I shall try. Dr. Mozak, we are delighted to have you with us. Here is your audience for the evening. We are a group dedicated to the good works of Alfred Adler and his system of change. Work us over good and get us to learn.
It's good to be back in Minnesota. I've been here, I don't know how many times, especially since 1970 when the school was founded. But in 1943, courtesy of the U.S. Army Air Corps, I spent 7 months here. The day I arrived, it was snowing, and it's still snowing. There's one correction, Roger. I joined Dreikurs in January of 1951, not in the 60s.
I'm way off.
And similarly with Dr. Shulman, who
Thank you.
joined us at the same time.
Thank you.
Now, you've picked 3 topics for me to talk about today and tomorrow all day. And I've taught courses on each topic. So actually in 2.5 and 3 hours, I'm not going to be able to give you too much material, but we'll do the best we can. At least you will have the flavor of how Adlerians think and some of the things that they do. And since we promote the idea of the creative therapist, and we don't feel that people should just parrot somebody else, even if they're very, very gifted, we're going to invite you in your career to come up with more innovative things that we haven't discovered in the last 50 or 60 or 70 years, and advance Adlerian psychology. So with that caution that we're just going to do a surface reading sort of these topics, I'll proceed. Actually, Dreikurs said, and he was wrong. Oh, I feel that that's a compliment, because a therapy or a therapist who does not change his mind about things has never learned anything about what he's doing. He just learned some initial stuff and he's stuck with it. That's it. And unfortunately, even though he had a poor command of the English, students and colleagues through the decades have persisted in repeating the same erroneous statement. The statement is that there are 4 stages in Adlerian psychotherapy. Those 4 stages, people have used different names for them. First of all, relationship. Secondly, analysis, what the patient's all about. Reorientation, giving the patient a new way or a different way of looking at things than the one he's been accustomed in terms of his lifestyle. And the 4th so-called stage is change, because it ain't enough just to know what you're all about or what's ailing you and that kind of thing. If you don't do it differently, then it doesn't really make very, very much difference. All you've had is a good discussion. I'm reminded of an old therapeutic story of 2 men who meet on Michigan Avenue in Chicago. And one says to the other in greeting, "Gee, Tom, I haven't seen you in such a long time." And Tom replies, "Gee, I've been so busy." "What have you been busy with?" Well, I'm in Freudian analysis. I go see my analyst 5 times a week. It takes out a good part of my day, and in between I think about what we've talked about and that kind of thing. And his friend interrupts him and says, gee, you're the first person I've actually known who's in analysis. Is it as great as they say? It's magnificent. Nothing like it. It's the best thing I've done. And the other fellow says, gee, you know, I don't know too much about Freudian analysis, but there's always been a question that bothered me. Well, what's the question? Perhaps I can help. Okay, you mean if Van Gogh had been in analysis, he wouldn't cut off his ear and send it to the prostitute? And the guy in analysis says, oh, he still would have done that, but at least he would have known the reason why. Now, many therapies settle for that as the goal of psychotherapy. You know the reason why. That is not sufficient for the Adlerian therapist. Insight for us has to contain a component of change, otherwise it's a lovely discussion at best. So, these are the 4 alleged stages. But a stage implies a definite period of time which is followed by another definite period of time. So first of all, you deal with relationship. That's stage 1. And when you get through dealing with relationship, you go to stage 2, which is analysis, etc. And we don't do that at all. These 4 are not stages, they are processes. And these processes proceed through the whole length of therapy. You're always working on relationship, you're always working on analysis, you're always helping the patient to orient himself, and certainly if you're a good Adlerian therapist, you're going to get them to change, you're going to move them along. In fact, one of my students in Chicago labeled me as the head of the Mossack Transportation Company. Move them along. So they are processes, and don't pass along Triker's errors to others. They are not stages. Because I get questions, well, how long does stage 1 take? Or how long does stage 2 take? And it doesn't. It takes from the beginning of therapy to the end of therapy. So tonight, I'm going to talk about one of those processes, and that is relationship. And some of the things I'm going to say are rather simple. But unfortunately, psychologists and psychiatrists are not known for doing the simple thing. For example, they never use simple language when complex language will do. Even if they have to invent a couple of words that haven't existed until that time. So they may seem simple, but they're important nevertheless. And then, as I speak, I'll give you some more complex things that we do or we think about when we are engaged in relationship. First of all, if you are going into private practice, then you will have to establish the kind of decor you like in your office. Now, in hospitals and clinics, you generally don't have to do that. They have pale, sick, green masonry walls that you can't even nail a picture into because the nails will damage the plaster and that kind of thing. So it isn't just a matter of pleasantness, although I think that's a factor to take into consideration. When I had to plan my latest office, it occurred to me that I had, up until that time, been constructing a space which I thought my patients might feel comfortable and like. And I certainly like to construct that kind of space. But my patient only spends 1 hour a week there. I spend over 40. So it occurred to me that maybe I ought to think about some of the things I might like, because I live there more than my patients live there. Now, you don't have this kind of choice in institutional psychotherapy. Whatever the hospital provides, the prison provides, that's what you work with. It can be terrible therapeutically, but you don't have very, very much choice. But in private practice, you got a choice. And there are certain things to take into consideration outside of pleasantness and that kind of thing. If you set up a room with you on one side of the desk and a patient on the other side of the desk, you are setting up a space which is consonant with the medical model of psychotherapy. That's the way doctors operate. The expert on one side of the desk and the supplicant on the other side of the desk. You know, I got trouble, say, doc, fix me up. You see. And you are already setting up, without knowing it perhaps, a therapeutic model. You're inviting the patient to behave in a certain way. And in the medical model, the patient can be ignorant of anything that bothers him beyond the fact that it bothers him. He comes and he says, I hurt, do something. And many times he remains so passive that the therapist is invited to do all the work. Now, that's a perfectly acceptable way to operate if you accept the medical model of psychotherapy. I do not. I had the good fortune to get my earliest training with Carl Rogers, and he didn't accept the medical model, and he taught us not to accept the medical model, so my office is the living room. It has nice easy chairs and drapes, candy on the desk, flowers. I like flowers. And it is a living room. Consequently, we are setting up a situation of two equal collaborators, maybe not with equal knowledge of psychotherapy or psychology, but there is nothing that separates us. We're just friends, as it were, talking about something which is important, which friends often do. And neither of us has all the answers. Consequently, the therapist is invited to listen to the patient rather than the other way around, the patient being invited to listen to the therapist. And you have to decide which of these things you would like to approximate. Secondly, many therapists do not know enough to shake hands with the patient or doing something similar. Now, you may be one of the 5%, or at least agree with one of the 5% of American psychologists who feels that to shake hands with a patient is unethical. Now, personally, I think that's nuts. In fact, rather than being unethical, it sounds rather inhuman. And about the only time I don't shake hands with a patient is if they're severe obsessive compulsives. I don't want to get germs all over them. But other than that, you have to remember to greet your patient, to invite him to make himself comfortable in your office. When I see a patient sitting like this at the edge of his chair, ready to take off if I ask him a question he doesn't like, I usually tell him something like, I only eat one patient a day and I've already done that. So you have to make the patient comfortable, and novices don't appreciate this, because when the patient comes in, they say, well, I'm going to ask you a few questions, or I'm going to show you 10 ink plots. They haven't actually invited the patient to be comfortable in a situation. And if he is not comfortable, you're not going to get a good reading on him. You're not going to help him very, very much. And if you do that kind of thing and make him uncomfortable, he will give you an often seen diagnostic sign. He'll be looking at his watch. Isn't it time yet for me to leave? So make your patient comfortable. Sometimes I do nothing in an initial interview other than make him comfortable. Let's have a chat. Think the Cubs are going to do well this year? And we may not get to the kinds of stuff that some therapists have to do in getting information. I can remember, come to think of it, when I was in the Army, we drafted so many people, we had to do psychological exams on a zillion people. There were 16 million Americans under arms in World War II. And we just couldn't do full-length psychological examinations on them. So some psychiatrists thought up an examination. As you went through the line, they looked in your ears, they looked in your mouth, and listened to your heart. And then you got to the psychiatrist or psychologist who greeted you with, when was the last time you fucked your mother? If you came up with an answer, I'm not kidding. That's a psychiatric examination in World War II. And you know, the psychiatrist didn't even look up because there were just so many men coming down the line. So keep your patient comfortable, and if necessary, sell them on it. You know, let them know that nothing terrible happened, and some people even get better. I add something to that, which I will tell you about later. But do that at least. Use whatever people skills you have to accomplish that kind of thing. Next, use the patient's idiom. don't talk to every patient with your idiom. Because if you do, you may not get answers, you may get confusion. For example, one of my trainees sat down to do a lifestyle with a patient who came from a lower socioeconomic status. And he said to the patient, "When did you enter puberty?" The patient said, "What's that?" Well, certainly they couldn't talk about puberty if you didn't know what the heck it was. So remember, not everybody talks like you. Not everybody has the same experiences as you. But if you want to get something across to them, namely something like, "I understand you." See, I never have trouble with, anymore, with a Roman Catholic patient, any Roman Catholic patient. Because as they enter my office, they encounter a plaque, which is in Latin, and it's translated on the back. I can't read Latin. And it says, "This office is dedicated as a holy place by the Carmelite Fathers of North and South America." Now, if the good fathers endorse me, then they can sit back and relax and make contact with me and I with them. And consequently, you will have to learn a lot of idioms because of the diversity of the patient load that you will have. You may pick, if a person is interested in music, musical allusions. If a person is an engineer, you may use engineering allusions. If a person is of a certain ethnicity, whatever it may be, you may use those. And if a person is of a certain religion, you may use those. Consequently, it's important that you get knowledge and perhaps training in various idioms. If all you know is psychology, you don't know enough to be a psychotherapist. You have to know law, you have to know sociology, you have to know about ethnicity, religion, and if you don't, you may not get where you want to go with the patient, or you may get there, but it will take a heck of a lot longer. So, a priest, I treat a whole lot of clergy, although I'm not Catholic, tells me that he went to the funeral of a loved one. And he's castigating himself because he couldn't cry. And I asked him, "Why can't you cry at a funeral of a loved one?" He said, "Because it is not manly." So I said to him, "Do you know the shortest sentence in the New Testament? Jesus wept." And I use a bit of irony. I say, ain't it too bad? He wasn't much of a man. Nobody looks up to him. So you have to know all of these kinds of things to make contact with different patients. I may talk about that more when I talk about tactics tomorrow, but we'll leave it at that for now. You have to know a whole lot. Next, Carl Rogers taught me that you have to establish a warm, permissive, accepting, kind of situation. And what way to establish warmth is, you know, by stuff like greeting and that kind of thing. But in addition to that, it's possible to laugh together. So Adlerians use a whole lot of humor in the therapeutic situation. And I've written a book, which you may or may not have here, Ha-ha and Aha, the role of psychotherapy, the role of humor in psychotherapy. And Adler felt that you ought to keep therapy light. Even if you talk about serious stuff, you ought to keep the therapy light. It should not be weeping and wailing and gnashing of teeth, although patients will do that too, here and there. But as far as the therapist is concerned, we ought to keep it light, even if we keep it damn serious. But there are other ways of establishing warmth. And again, I refer to Carl Rogers. If you watch a video of Rogers doing psychotherapy, it looks like every fiber in his body, every cell is tuned in to the patient. There is nothing else in the world that's important at that moment. The only thing that's important is the patient, what he's saying, what he's feeling, what he's doing. Next, you have to let the patient know that he's free to be himself, to say what he wants to say, to be angry if he wants to be angry, etc. There are very, very few things which are not permitted. You cannot break the windows in my office, you cannot throw ashtrays at me, etc. But other than those extreme things, if you want to talk about this, that, or the other thing, anything goes. To be acceptant means here is a human being. This is not a case. Because if it were a case, wouldn't it be nice if the patient brought his troubles and stayed home where it wouldn't be a nuisance to the progress of therapy? So this comes as a new vision to many patients who feel that they're somewhat below human. And people have treated them that way perhaps many, many times, and give you a whole history of times when people have treated them not as a human. And we have to be non-judgmental to a large extent. To a large extent because, first of all, you're a human being, and human beings judge. Some more than others, but they judge. But rarely you run across patients whom you cannot deal with for whatever reason you cannot deal with, because you think that they are pretty terrible people, and you even have the feeling, which you tried to squelch at times, that they don't even deserve to have nice things happen to them, and that kind of thing. If you get one of these patients, it's not terrible, but do them some justice and refer them to somebody else who can stand them. I can only remember 2 instances in my whole career where I just could not stand 2 people. One I was going to kill. Both of them were Nazis. And the one I saw in Montreal at the Montreal Librarian School indicated that Hitler had done a good job, but not good enough, because he did leave some Jews living. And what he wanted in therapy was some information on how he could stoke up the ovens to get rid of the rest of the Jews. I sat on my hands, otherwise I would have slugged him, and I referred him to somebody else. But outside of those extremes, I am generally non-judgmental. The person comes, he has a problem, let's see what we can do with the problem. And I learned that when I was a math major. Problem, you look at it and you see what it means, and you bring it to bear on the problem. So basically, you should be non-judgmental. But there are times when you will not be. Now, I've written somewhere that therapy, all therapy, not only Adlerian therapy, but Adlerian therapy primarily, is based on faith, hope, and love. With respect to faith, you have to have faith in yourself as therapist. If you don't, you won't do a good job, or perhaps any job at all. You know, there's a story of the man who came to visit an Adlerian therapist, outlined his symptoms and that kind of thing, and said, "Doctor, can you help me?" And the therapist answered, "I think so, but then who am I to say?" If you have that kind of attitude, you'll probably get nowhere with your patients, not only because you won't know what to do, but the patient will realize that they're in the hands of somebody who doesn't know his business. And to some extent, those of you who are young and novices and that kind of thing, had better make sure that you work under supervision, so somebody can help you with those things that you don't know, so that you will not damage your patients. In addition to that, you have to have faith in the patient. Now, one way of not having faith in the patient is to do prognosis. This kind of patient never gets well. Well, that'll be a self-fulfilling prophecy. They'll never get well because you believe they'll never get well. When I was a student, we had a diagnosis of psychopathy, which was just terrible, the name. And on that basis, the therapist of that time never took such a patient into therapy because he was hopeless. As far as I'm concerned, I do not do prognosis. I do my job. And even if I do my job very, very well, and people might say, "Gee, wonderful what you did with the patient," it might not go anywhere because the patient won't let it happen. So you have to have faith in you and faith in them. Now, my faith, and I express it to patients, is I firmly believe that everybody can be better than he is at this particular moment. So let's find a way of helping you to get better than you are right now. How far that will go, we'll see. But meanwhile, let's see what we can do about helping you to be better than you are now, because everybody can be better than he is right now. And that gives some patients some encouragement that they haven't had before. Next, there's hope. Some people come in and say, I've seen 6 therapists already. I don't know why I say you, but gotta do something. Nothing seems to work. Others come in, they're depressed, and others come in with suicidal thoughts and that kind of thing. And you have to give them hope. Now, you aren't going to tell them, gee, every patient I ever treated got well, etc., or some such thing like that, because that wouldn't be true. But there are many things you can do to give hope. For example, I was treating a man who was depressed. And he really wasn't depressed on his own account. He had a young son who, when he was 10 years old, developed Hodgkin's disease. And he was treated for 4 or 5 years and went into remission. And that was good. Everybody relaxed, that kind of thing. And about 3 years later, the kid had a recurrence. And this time, University Clinic said, doesn't look like he's going to make it. The kid went into depression and decided to kill himself without killing himself. He'd take the family car at 2 o'clock in the morning and go down the highway at 100 miles an hour, hoping that he'd have an accident, you know. And the father came in and he just cried, I want to help him, I want to help him. I feel so helpless, I can't do it, etc. And no matter what I do to encourage him, and we all tell him we in the family that we love him and all that, he gets progressively more depressed because he knows he's going to die. I told the father, when his birthday comes up, buy him a 10-year U.S. savings bond. And on the basis of that, the kid went back to college and came into therapy because his depression was interfering with his schoolwork, etc. So a creative therapist will think of hundreds of ways of instilling hope. Next, there's the matter of love. It goes by a lot of names. Rogers called it unconditional positive regard. You think that the person is an okay person, regardless of what he has done or hasn't done, or isn't doing or is doing, etc. But not everything boils down to unconditional positive regard. There's actually demonstrating caring, love, etc. to patients. For one thing, You look like you care that they've come back to see you. They're worthwhile human beings. You have a good relationship with them and that kind of thing. But there are other things. You see, when a person's hurting, it sometimes helps to put a hand on their shoulder, which indicates, I'm with you in this, etc. The most extreme case of caring, I inherited Dr. Dreiker's first patient. After he died, she came back into therapy after, 30 years out of therapy. And her husband had just died, and now she wondered what she was going to do with the rest of her life. She had no family, and she was concerned. She liked to travel. And what if she dropped dead in the middle of, Cairo or someplace? They wouldn't even know what to do with the body. She had no family, no nothing. So I gave her a card, my card, and I said, on the card, in case of emergency, please call at this number. And then I made a promise to her, because she didn't want to die alone. And I said, if I ever hear that you are dying, wherever you are in the world, wherever I'm in the world, I'll fly out and hold your hand while you're dying. And every couple of months she called me and say, Doctor, you remember your promise? And I said, yeah, I remember my promise. And so it went. Well, a couple of years after I made this promise, I had gone to Europe, and I came home with my wife on a Saturday night, and we had traveled about 36 hours. I was short of sleep. And my kids were waiting at O'Hare Airport, and I thought they were there to take me home. And they told me that they had received a call from Great Lakes Naval Station that my patient was there, hospitalized, had been given the last rites of the church, and she was going to die. So I told my family to take a cab home, and I took the car and drove 40 more miles, and entered her room at the naval station, and she was all wired up with all kinds of stuff, comatose. And I sat down next to her bed, and I held her hand. And I just sat there and held her head. And about 1 o'clock in the morning, she opened her eyes and she said, "You're here, you're really here." And I said, "Yes, I keep my promises." And she smiled and she closed her eyes again. And I sat and held her hand. And about 5 o'clock in the morning, she opened her eyes again and said, "I can't believe it, you're really here." And I said, "Yes, I'm really here, and I'm holding your hand." And of course, having been given the last rites of the church, she knew that she was dying. And at 6 o'clock in the morning, the Navy doctor came in, and he gave her an examination. And I said to him, "I've been out for 2 days now. If you assure me that she's going to stay alive till noon, I'll drive home, I'll take a shower, and get some breakfast, and I'll come back." He said, "She's good till noon." So I said, "Are you sure you promise?" He said, "She's okay till noon, but her kidneys have shut off, and I don't know that she'll last much beyond noon." So I got in my car and drove 40 miles back home, and got breakfast and showered. And before I got back in my car to return to the naval station, thought to myself, what if the doctor was wrong? I don't want to make a 40-mile trip and find out that she's dead. So I called and I got the doctor. I said, is she still alive? And he said, she's sitting up having breakfast. And I said, wait a minute, we're not talking about my patient. He says, yes, we're talking about your patient. And I said, you told me that her kidneys shut down. He says, can I help him? They turned down again. So I drove back to the hospital and had a chat with her. And she thanked me for coming to hold her hand. And she lived 2 more years. That time she didn't make it. So, in all kinds of ways, you have to show caring. It's enough that they're human beings to care. But when they are suffering human beings, they need even more caring. So again, tomorrow I will give you some techniques for demonstrating caring. I think I'm going to stop here with that aspect and move on to another aspect of relationship, and that is resistance. Kuypers made another erroneous statement, and don't feel I'm picking on him, because in the late 1960s, I met Kurt Eckler, who was Anderson's psychiatrist, somewhere in the world I can't remember anymore. And it was the start of research in sleep and dreams. And I said to Kurt, how do you square away current research on sleep and dreams, which indicate that people dream a half a dozen times every night, and all people do, with your father's statement that well-adjusted people, and he included himself in that category, never dream because they solve all their problems in their waking hours. And Kurt smiled at me. He said, in his lifetime, my dad spoke plenty of nonsense, and this was one of his bits of nonsense. And I think that was a compliment. It showed that Adler's theory evolved. So I would like to give you the one statement that Adlerians know about resistance. It is grammatically wrong even. Resistance is when the goals of the therapist and the goals of the patient do not coincide. Now, my English teacher in high school and college informed me that a thing cannot be when. So it doesn't even do well as a grammatical statement. But it is true that in much resistance, the goals do not coincide. But there's so many other things that resistance is about. For example, there are people who resist without resisting the goals of the therapist, except perhaps very, very broadly. For example, you have patients who come in 15 minutes before the end of each hour. They're not going to let the therapist get his or her hooks into them. And the 15 minutes, they talk about the weather and all kinds of stuff like that, so that even more, the therapist can't nab them. Now, my own definition, a definition shared by some of my colleagues, is that resistance is manifested or let me change that. Resistance is a manifestation of behavior which impedes the progress of therapy. So if you keep missing appointment after appointment after appointment, that's going to impede the progress of psychotherapy. If you're going to talk about trivia, it's going to impede the progress of psychotherapy. If you fight and argue with your therapist over and over and over again, you're going to do a lot of fighting, but not very much learning. So anything which impedes the progress of psychotherapy is resistance. But here's something that psychotherapists don't seem to know because they never comment on it. Whenever something comes up which impedes the progress of psychotherapy, they assume that it is the patient's fault. He's being a bad guy, he's resisting whatever all the good things that the therapist is trying to do for him and about him, and etc. But if you look at it, there can also be therapist resistance. The therapist can be doing things that impede the progress of therapy. One common thing in institutional practice is, well, let's have another cup of coffee in the lunchroom. The patient ain't going anywhere anyway, so it doesn't make any difference if I come in 15 minutes late. He's going to be there. That, of course, violates his humanity. He's entitled to have your services and entitled to have it on time, barring some emergencies or something like that. But some therapists lose sight of that. But even in private practice, or any practice, you find that therapists can do things which will halt, delay, or whatever